Hello, everyone, and welcome. Today, we're going to get right into a topic that you will see day in and day out in your surgical postings, the clinical examination of an ulcer. We'll be going through it step by step using the framework from the latest edition of SDAS's Clinical Surgery. Trust me, getting this right is absolutely essential for your ward rounds, your final exams, and especially for those OSCEs. So here's our roadmap for today. We'll start with why this skill is so critical. Then we'll cover the key diagnostic frameworks, basically the patterns you need to learn to recognize instantly. After that, we'll walk through the SDAS protocol itself. Then we'll apply everything to a typical OSCE case, and I'll wrap up with some pro tips to help you perfect your presentation. All right, let's begin with the big question. In this modern age of MRI scans and fancy lab tests, why do we still put so much emphasis on a proper physical examination? Let's talk about that. The answer really comes down to this number, 80%. A thorough history and a proper examination will lead you to the correct diagnosis in 80% of ulcer cases. Think about what that 80% really means. It means that well before you order a single test, just by using your eyes, your hands, and your grain, you can already start to figure out what you're dealing with. Is it benign or malignant? Is it a venous problem or an arterial one? This skill right here is what separates a student who just follows orders from a clinician who truly understands the patient. So now that we know why this is so important, let's get into the specifics. Before you can master how to do the examination, you first need to understand what you're looking for. This part is all about recognizing those key visual clues. Now, I want you to listen very carefully. The single most important diagnostic clue in any ulcer is its edge. If you remember one thing today, make it this: a gently sloping edge that points to a healing ulcer or a venous one. A sharp, punched-out edge, you should be thinking arterial, neuropathic, or even syphilis. An undermined edge, where the skin literally hangs over the base, that's a classic sign of tuberculosis. A rolled, pearly white edge is the hallmark of a basal cell carcinoma, a rodent ulcer. And finally, if you see a raised, everted edge that looks a bit like a cauliflower, you must suspect squamous cell carcinoma. This is pure gold for your exams. Okay, let's quickly compare the three most common ulcers you'll encounter. First, we have the venous ulcer. Look for it in the goiter area of the leg. The key signs are normal pulses and that brownish pigmentation of the skin. Now, contrast that with an arterial ulcer, which is often on the dorsum of the foot. This one is very painful, and the crucial finding is absent pulses. And third, the trophic, or diabetic ulcer. This will be over a pressure point, like the sole of the foot. And what's the giveaway? It's painless, because of the nerve damage, and you'll often see that thick, hard skin, that callosity around it. Now for a few special cases you absolutely cannot afford to miss. A Marjolins ulcer. That's a squamous cell carcinoma that has developed in a chronic wound, like an old burn scar. You'll see that classic everted edge. Basal cell carcinoma. You know this one. It has that rolled, pearly border and shows up on sun-exposed areas of the face. And finally, and this is so important in our context here in India, you must always have a high suspicion for a tubercular ulcer. Remember, it's undermined, bluish edge, often with associated swollen lymph nodes. With diabetic ulcers, understanding the stages of progression is a matter of saving a limb. It all starts at stage 1, just inflammation, which is manageable. By stage 3, you're dealing with a deep ulcer needing specialized care. But if it gets to stage 4 with infection in the bone, osteomyelitis, we're talking about amputation. You can see why catching this early is so incredibly vital. Okay, we've now arrived at the heart of our lesson, the SDAS examination protocol. I want you to think of this as your checklist, your systematic guide. You need to learn this sequence and follow it every single time, without fail. It's what will ensure you never miss a thing. It all begins with a good history, and you have to follow this order. You ask about the duration, the onset, did it just appear or was there some trauma? Then pain. Is it painful? Remember, pain suggests ischemia. Painless suggests neuropathy. You'll ask about any discharge and how the ulcer is progressing. Then you move on to associated symptoms, past history, and of course personal history. Asking about things like smoking and footwear is crucial. After the history, it's time to look. Inspection must be systematic, covering these 8 points. You'll start with the precise site. Then, its size and shape. How many ulcers are there? Describe the margin. Then the all-important edge type. After that, look at the floor of the ulcer. What is it covered with? Healthy granulation tissue or unhealthy slough? Note the type of discharge. And finally, you must look at the surrounding skin for things like pigmentation, swelling, or varicose veins. Next, you feel. Gently palpate for any tenderness, check the consistency of the edge, and see if the ulcer is fixed to the structures underneath. Then comes the step that students so often forget, and you must never skip this. You must examine the regional lymph nodes. This is non-negotiable. It's how you check for infection or malignant spread. Only then do you perform your special tests, checking sensation for neuropathy, feeling for pulses to rule out arterial disease, and looking for varicose veins. All right, theory is one thing. Now let's put it all into practice. We're going to walk through a classic OSCE case, the kind of scenario you are almost guaranteed to face in your exams. So here's your patient, a 60-year-old gentleman with diabetes who has a non-healing ulcer on the sole of his right foot for the last 8 months. On inspection, you see a single 3 by 3 centimeter ulcer with a punched-out edge. There's a callosity around it. On palpation, it's not tender. So let's connect the dots. What do we have? A punched-out edge. We have absent sensation, which is the hallmark of neuropathy, and it's on a classic pressure point. These findings all point in one direction, leading us straight to our provisional diagnosis, a neuropathic ulcer secondary to his diabetes. You know, getting the diagnosis right is only half the battle. Presenting your findings clearly and confidently to your examiner is what really shows your competence. This last section is all about how you can perfect that delivery and really stand out. Now, this is what a perfect OSCE presentation sounds like. Just listen to the structure. You would say, this 60-year-old gentleman, a known diabetic, presents with a non-healing ulcer on the sole of his right foot for 8 months. On examination, there is a single 3 by 3 centimeter ulcer with a punched-out edge, a sloughy floor, and surrounding callosity. The base is fixed, and there is loss of sensation over the area. The regional lymph nodes are not enlarged. My provisional diagnosis is a neuropathic ulcer secondary to diabetes. I would now like to proceed to investigations. You see, every word has a purpose. Mentioning the punched-out edge gives the diagnosis away. Describing the floor shows you've assessed the wound status. Loss of sensation confirms the cause. And mentioning the lymph nodes proves you examined the whole limb, not just the ulcer. Let's finish with the common mistakes so you can avoid them. The biggest ones are forgetting to describe the edge and floor and completely missing the lymph node examination. It's so common. So my pro tips for you are simple. First, always describe the edge type first. It points you to the cause. Second, examine the entire limb and the patient as a whole. And finally, especially in our context, you must always say out loud that you are ruling out tuberculosis and malignancy. And there you have it. That completes our guide to the history and examination of an ulcer, as per SDOS clinical surgery. I truly hope this systematic approach helps you feel more confident in your wards and in your exams. If you have any questions at all, please leave them in the comments. And of course, like and subscribe to Bedside Clinics for more sessions like this. Thank you for your attention.